Okay, we're recording. So I think we'll get started, everyone. It's at the top of the hour. My name is Kristin Musselman. I'm a scientist at the Toronto Rehab Institute and an assistant professor in the Department of Physical Therapy at the University of Toronto. And on behalf of the Neurosciences Division, it's my pleasure to welcome you to today's webinar, which is titled Activity-Based Therapy Across the Continuum of Care in Canada. First, just a couple of housekeeping details. Please all mute your mics or your phone lines at this time. I think most people are muted, which is fantastic. That way we avoid feedback during the presentation. If you have any questions, we're planning to have a question and answer period at the end of the talk. So just hang on to your questions or feel free to send them via chat as our speakers are talking. So it's my pleasure to introduce today's speakers, or my co-presenters. So we have Dr. Jennifer Leo, who's the director of the Stedworth Center for Professional and Physical Achievement and the Faculty of Kinesiology, Sport and Recreation at the University of Alberta. We also have Shane McCullum with us, who's a physical therapist and the clinical trials manager at the Stan Cassidy Center for Rehabilitation in New Brunswick. John Chernesky is the consumer engagement lead at the Rick Hansen Institute and the vice president of the North American Spinal Cord Injury Consortium. And Kristen Walden is also with us, who is also a physical therapist, and she's the national clinical liaison for the Rick Hansen Institute. And Heather Flett was planning to be part of this webinar, but unfortunately she is ill and isn't able to join us today. So hopefully we can bring her perspective to the presentation. So what we're hoping, there's three things we're hoping to achieve through this webinar. We want to describe the characteristics of activity-based therapy, and activity-based therapies are applicable to neurological populations. So it's not just spinal cord injury, but the focus of the work that we're going to talk about is on SCI. Where through the different perspectives of our speakers, we'll identify some of the challenges of implementing ABT in rehab and also community settings. And we'll also consider some possible solutions to these implementation challenges. So here's an outline of what we hope to do over the next 45 to 50 minutes. We're going to give you a brief introduction to activity-based therapy. After that, our speakers will give their perspectives on how ABT is being used, and then those implementation barriers, but also facilitators. And then we'll end with an overview of a summit that we had recently, this past March in Toronto, where we were discussing activity-based therapy and increasing access to activity-based therapy for individuals with spinal cord injury. So we'll share with you some of the outcomes from that summit. So the research supporting ABT has been decades in the making, and there's a significant amount of animal and human research that has come together to contribute to our understanding of how therapy could be delivered after damage to the nervous system. And this has led to the development of the approach called activity-based therapy. So activity-based therapy is an intervention that targets activation of the nervous system that is affected by an injury or damage. So in the case of spinal cord injury, it's activation of the neuromuscular system below the level of the lesion. But likewise, if you're working with a client post-stroke, it may be activating areas that are affected by the damage that's caused by the vascular incident. So the goal here is to promote neurorecovery, to help the individuals regain function. So you are targeting areas of the body that are affected, have paralysis. So it's very task-specific training, but at the same time, equally as important is the aim is to help reduce the risk of secondary complications associated with their injury. So an important point about ABT is it's both task-specific practice, but also exercise, and you really need the two pieces together. And that's because we know that task specificity, but also intensity and repetition is needed to promote or encourage neuroplasticity. Along with that, there's many other benefits, that task-specific exercise can have for the body, such as improved in cardiovascular function, increasing bone density, effects on cognition, and also quality of life, and the list goes on. But neuroplasticity really is at the center of our understanding or it really is the foundation, I guess you can say, of activity-based therapy. And that's what's being shown in the diagram here, which was published by some of our colleagues in the United States, who Andrea Behrman, and that group that have really focused on locomotor training as a type of activity-based therapy. So the idea is a activity-based therapy is going to adopt the principles of activity-dependent plasticity. So the training needs to be task-specific. That's an important component of the intervention. And so you're trying to have an individual recreate a movement using the parts of the body and the muscles that would typically be activated if there was no damage to the system. So again, you are activating those areas of the body affected by the damage or below the level of lesion. But also very important to the concept of activity-based therapy. It's not just the execution of the movement, but it's also having appropriate sensory input coming back into the system. And so that's often where some of our modalities or equipment can assist. So things like treadmills or body weight supported treadmill training, electrical stimulation of the various forms of electrical stim, so FES, but now more recently epidural stim is being studied as well. So the idea here is that you're producing movement, but at the same time creating a situation where you're getting the appropriate sensory input coming back into the system as well. So in the case of an individual with a spinal cord injury, what we're aiming for with ABT is to have repeated activation of circuitry within the spinal cord. And this is definitely, below the level of injury, so where, their spinal cord injury does affect their function and their muscles, but also above the injury if that's appropriate. So it depends on what task you're doing. I mean, if you're doing arm and leg cycling in an individual with paraplegia, of course, you're going to engage the arms in that movement, even though there is no damage. And what you want to see that as you engage in ABT is you're actually trying to modulate the amount of excitability within the nervous system. That again comes from the sensory input that's provided, but also the task that you're doing. The aim here is to encourage appropriate movement patterns, minimize compensations as best as possible. And as mentioned, it's guided by our principles of neuroplasticity. So can't reinforce this enough, but it needs to be task specific. There needs to be repetitions. So we know in the animal literature, we're talking about hundreds or thousands of repetitions in a day in order to see those changes within the nervous system. But then equally as important, it's not just repeating a movement, any movement. It needs to be a movement that is not fully learned yet. So there needs to be some element of challenge. So if you're just practicing a movement that is already within that individual's repertoire of movements they can perform, that's not going to necessarily be neuroplasticity. You really need to be challenging the system and practicing tasks that they are not quite able to achieve. So the literature looking at what ABT is will describe some of the key components in different ways, but really what you're seeing on this slide, the two columns are essentially the same. So on the left was taken from sort of one group in the way that they describe ABT, and then on the right is from a group that's more focused on locomotor training and using the words and their terminologies for what needs to be part of an activity-based therapy program. So just look on the left first. What this group is saying is that you need, in order to call a program ABT, there needs to be some element of pattern motor activation. So that's engaging in repetitive motor tasks, things like walking or cycling. There also needs to be an element of non-patterned motor activation. So an easy example here would be a task that's more looking at strength. So you could be doing a strengthening exercise or incorporating that more into a functional task like a sit to stand transfer. And then lastly, and I think this piece is, integrated into the previous two, but is the element of sensory stimulation. So there needs to be sensory information being flowing back into the system to help regulate the excitability, like we mentioned in the previous slide, the state of excitability of the nervous system, but also appropriate sensory information is an important piece of producing movement. On the right side, so these components of ABT, again, it's focused more on a locomotor training program, but there needs to be an inclusion of weight-bearing activities, and that's not just weight-bearing of the legs, but that's all 4 limbs, which could be done all together, or you could be doing 1 or 2 limbs at a time. They believe FES should also be included in the ABT program. So there's the sensory piece, which we've talked about, but also to help activate muscles to be firing at the appropriate times, and whether it's a walking task or another task that you're practicing. The training needs to be task specific and massed, which means lots of repetitions. And in this case, because it was focused, the overall program was focused on the lower limbs, they always included an element of locomotor training, which could be done in a variety of ways. So it can be done on a treadmill or off a treadmill, with body weight support or without body weight support, but also in aquatic environments. That could be part of the ABT program as well. A really key piece of ABT is the intensity. So we already talked about how there needs to be lots of repetitions. So just to give you an example of what's recommended for an ABT program that is focused on the lower limbs and locomotion, this group has recommended at least 60 sessions on a daily basis for at least 1.5 hours per day. I'm sure many of you listening can appreciate how difficult it must be to achieve that level of intensity or dosage. And so you'll see in the literature some people talking about a modified ABT approach, where the modification is really around that dosage, and just, in many situations it's not possible to achieve that very high intensity. Otherwise, you can still incorporate all the other principles of ABT and neuroplasticity. But if you can't really achieve that very intensive frequency and dosage, then people are starting to refer to the programs as modified ABT. And this figure is showing a scatter plot of some studies that were included in a meta-regression of the dose-response relationship in stroke rehab. And I think it does a very nice job of highlighting the importance of dosage and how that will influence outcomes after a rehab program. So in this meta-regression, they have 1,750 participants with stroke included, and that's across 30 different studies. And what they're plotting here is, on the horizontal axis is the number of hours that were spent in therapy. And on the vertical axis is their change from baseline. So basically, and it's plotted as an effect size. So a bigger number just means that they improved more, the group improved more with the intervention. And then you see a variety of different dots on the plot, and the blue dots represent a group of individuals who were in the control group for that study. And then the orange dots are the experimental groups, and the size of the dots reflect the sample size of the study. But what you can see is there is an upwards trend suggesting that the more hours you spend in therapy, then the more change that you see. And in this meta-regression, it was quantified, this relationship with all these different studies, and they did find a modest effect, meaning that more therapy will lead to more benefit. And I'm sure that's not surprising to anybody who's on this call. I think we know that already. But again, this is where the idea with ABT is that dosage and intensity is very important. And so if we reflect upon what's currently happening in Canada in our inpatient rehab, and I'm going to focus on spinal cord injury here, is, I'm sure not surprisingly to many of you, is that we aren't really achieving the number of repetitions or the intensity that we know probably would most benefit our patients. So this is a study, the one by Bogar from 2017. Many of you may have seen it, but it looked at 2 of the bigger SCI rehab facilities in Canada. And the researchers actually counted the number of steps that the individuals with spinal cord injury who were ambulatory, the number of steps they were taking in their PT sessions at admission, and then they also looked at it at discharge. What I'm showing in the little table is just the number of steps taken at admission, which was a median of 51 steps with the range in brackets there for you. And then by discharge, they're taking 115 steps per physical therapy session. So this is really quite a small number of steps in a given session, which is probably, 45 minutes or so. And we ourselves in Toronto did similar work. We, instead of counting steps manually, we did have the patients wear an accelerometer, which counted the steps automatically for us. And the real reason we did the study was to validate whether the accelerometer could correctly count steps during inpatient physical therapy sessions. But as a sort of secondary analysis, we actually looked at how many steps the patients were taking during their PT sessions, but also during self-directed time. So when they weren't in scheduled PT or OT, they were just, on the unit by themselves or with family in the afternoon. And what we found, we actually found higher numbers than what the previous study found. So we were finding on average people were taking just above 20 steps per minute in a given PT session, which equates to anywhere between 600 to 900 steps. And this is more towards the end of their inpatient stay when we sampled. So we were getting higher numbers, but one thing that we found is people are taking less steps during their self-directed time, which again probably isn't surprising, but I think indicates there's this window of opportunity to try to increase the amount of repetition or intensity people are achieving outside of typical PT sessions as well. So and then one other piece from another study, again, by the same group that looked at the number of steps at the 2 centers in Canada, they also documented cardiovascular responses or intensity during PT and OT sessions. And as you can see in the slide, basically they found that during PT and OT sessions, the patients are not reaching a heart rate that would suggest that they're working at even a moderate level intensity. And specifically only 13% of the inpatients met the required guidelines of 20 minutes at a moderate to vigorous intensity during their inpatient stay. So to summarize, we've talked about how ABT involves the activation of areas of the nervous system that have been affected by the injury, that it includes both pattern and non-pattern movement that is based on the principles of neuroplasticity. So it's intensive, it's task-specific, it's challenging, it's repetitive. And that, as best as we can tell so far, that probably that intensity or repetition is missing right now in our current inpatient rehab programs. So what we'd like to do next is we have 3 different individuals coming from 3 different perspectives, and they'll first tell you the perspective they're coming from and where they work sort of in their environment. And then what we've asked them to do is talk about how ABT is used currently in their facility or in their environment, and how do they think it could be optimized, again, from their perspective. And so, Shane, I think you were going to be the first one to speak. Is that correct?
Sure. Yeah.
Okay.
Perfect. So, as Kristen mentioned earlier, my name is Shane McCullum, and I'm a physiotherapist and clinical trials manager at the Stan Cassidy Center, which is the neuro rehab center for the province of New Brunswick. And I'll just quickly touch upon some of the equipment that we have that we use for ABT, and then some barriers and facilitators, along with some implementation tips that we have noticed here. So we're pretty fortunate here to have quite a bit of equipment that we are able to use for ABT. So some examples for FES equipment, we have the RT300 restorative therapies 300 FES cycle for upper extremity and lower extremity. We have the Excite, which is also from restorative therapies, so it's for arm and leg stim as well. We have an FES rower. We have BioNest for the hand and foot, the walk aid, and the Oddstock as other FES equipment, along with just the simple 2-channel devices. We have an EXO here that we have along with the University of New Brunswick that we're able to use. We participated in some studies looking at the Mind Move along with virtual reality, so we've had some experience with those. And then we also have some traditional cardio equipment some treadmills, SciFit, VitaGlide, arm bikes, and stuff like that. So some of the barriers are common barriers throughout rehab, not just with ABT. A big one is time. So trying to prioritize how much time you can put towards training and recovery versus compensation and discharge planning as you near discharge. And the time using ABT is not just during the sessions, but it's also setup time, learning to use the equipment, and then gaining expertise using it, adapting programs, which can all take time. So you're trying to prepare individuals for the real world, and it's nice when they have the ability to use the equipment here, but then what happens when they leave? So one thing that we've tried to do in order to get more buy-in on time is really collect outcomes in order to justify the use of ABT with patients, and then also to determine if someone's plateaued. So we have, we meet weekly with our physiatrists here. We have the ability to kind of talk with them, and if someone's still gaining and recovering quite well, we have the ability to, mostly with the physiatrist, but to prolong their inpatient stay in order to try and maximize their function before they go home. So that's something that I know it's not possible at all centers, but it gives us a bit more time to be able to use some of the equipment. Second one is money. So equipment is often pricey. It doesn't always align with organizational priorities, so trying to determine what equipment is worthwhile having. We've been fortunate, most of the equipment that we have that I mentioned earlier, we've been able to get through research money, so either money left over from studies or through specific grants, some through donations, some through capital equipment, and other ways. So and then but one thing with that as well to think about follow-up costs. So we cycle and our excite and expire, or we need more, and things like that to think about as well, which is always important to think about how you're going to cover those follow-up costs moving forward. Another barrier is follow-up in the community. So once someone is discharged from here, how do you continue on with ABT or try and find other ways to continue to improve? Much of our province, just like much of Canada, is very rural, so it's difficult to have equipment in a lot of areas in order to continue with ABT. So we've been working a little bit, and I'll speak in a little bit about some ways that we've been trying to figure out how to improve that in the province. So a couple of facilitators that we have found very important is management buy-in. So it's really important to have management on board in order to allow for time for proper training, not just initial training, but also follow-up training, and then to allow time for use within rehab. So our management here is very, very hands-on, and they're very excited when we get the equipment, which is very good. And then also physician buy-in as well. A lot of our outpatients that get referred for equipment are referred by our physiatrists here, so it's important to have their buy-in. And then it's also proper training is a big facilitator, and it's not just initial training when you get a new piece of equipment. It's important to try and get as many people trained as you can when they first come, but it's also trying to think about what's going to happen when the therapist who's on leave or a new staff member comes. Who's going to train them? How is that going to work? Trying to have a champion or someone that takes priority with the equipment so that they can help with kind of the mentoring or coaching, troubleshooting, working together among peers with equipment. We often have that where one therapist has a question about something and another therapist has used it more recently, so they kind of go back and forth. So trying to figure that out, so it's ongoing training and learning. Excuse me. So some of the implementation experiences that we have. So it's easiest if equipment can be purchased with no restrictions. So as I mentioned, some of our equipment is purchased through research grants, which is great. But then there's a lot of times there's restrictions on that it can only be used through research for a certain time frame. So it's trying to figure out how we can do that and embed the research into clinical practice in order to actually use the equipment with as many people as possible. Having champions and teamwork is very important for continued improvement in use. And then having a plan at the very outset. So before as we're thinking about getting equipment, we try and have a plan to what can we set up to facilitate the use of this equipment, and what barriers do we foresee, and how can we help to mitigate those barriers. So instead of waiting until the equipment's here saying, oh shoot, we hadn't thought about this, trying to think upfront about how we can set it up for optimal use. And another thing implementation-wise that goes along with the intensity is trying to use the equipment early in rehab in order to maximize potential. So we try and really use a lot of the FES cycling and some of the equipment early on in rehab, and same with the EXO. We find that people trying to get the intensity is great, but if they're just relearning to walk, being able to take a few steps during a session is exhausting for them. So using equipment like the EXO, where they can actually take several hundred steps and keeping a good pattern and then changing the modes in order to make it so that they're doing more of the work has been very helpful for us. And I just want to go through one quick example of how we're trying to improve community use for some of the equipment. So we created 3 different FES working groups about 1.5 years ago between our physios and OTs and our rehab assistants as well. So we're looking at how to improve FES use here at the center, but then also how can we improve it in the community. So whether that's going to be through health centers or educating other clinicians in the province. So our first step for the community group was to create a survey, which we sent out province-wide, and we had 72 people who responded throughout the province, and mostly PT, OT, and rehab assistants. So we asked them about their current use and if they would like to use it more, and the current knowledge on FES. Excuse me. So our response was that about 67% were in the somewhat aware, not so aware, not at all aware on FES use. So about 2/3 were kind of in the lower half of that category. Only 22% were either extremely or very confident in FES use. 66% did not currently use FES at all with any of their patients. Some of the main barriers that they identified were similar to what we've experienced here: access to adaptive equipment, cost, accessibility, and availability of fitness centers in the community. And then one thing that we kind of are trying to figure out what we can do with now is that 85% of the respondents actually said that they would be interested in participating in either an in-person course or a series of webinars on FES to learn more and then see about how they could potentially use it. So that's something that we think we're trying to figure out what we can do with moving forward, but it might be a way that we can increase the use in the community here in the province. And that's all I have, so I'll pass it on, I believe, to Jen. And if there's any questions at the end, I'll be happy to answer them.
Thanks, Shane. So as Kristen had mentioned, my name is Jen Leo, and I'm the director of the Stedford Center for Personal and Physical Achievement at the University of Alberta. I've been in this role since October of 2018, so it's relatively new. Prior to that, I did my master's and PhD here at the University of Alberta with a focus on adapted physical activity. So I've been working in the community for, I guess, around 15 years or so. And so listening to Shane talk about ABT and what that looks like from the rehab side, my job here is to offer sort of that community perspective around what happens to individuals when they leave the rehab setting and they're trying to continue with their ABT within a community space. So the Stedford Center has been providing adapted physical activity and parasport programming for 40 years here at the University of Alberta. As a community-based center, we deliver services for nearly 1,000 children, youth, and adults experiencing disability. And we support professional learning for nearly 250 undergraduate and graduate students. Now, specific to ABT, here at the Stedward Center, we offer FES cycling. And so that's a part of our kind of suite of exercise programs for people with a range of impairments. Primarily, this exercise modality is used by individuals with spinal cord injury and MS. We currently have 4 FES bikes, and so we have a couple that have that are the RT300 that have the upper and lower body, and then a couple that just have the lower body. They're used daily. We have approximately 13 individuals specifically with SCI who take part in FES cycling about 2 to 3 days a week. So it's a very well-used program. I would say the capacity and the spots are about at 80% full right now. So it's a very well-used program. So as part of this continuum of care, we work very closely with the Glenrose Rehabilitation Hospital here in Edmonton. And so our hope is that we're trying to support individuals as they're transitioning from rehabilitation to community-based services, so that when they finish that rehab piece, that they still have an opportunity to continue to be active in their community. So within Edmonton, as I mentioned, we have 4 exercise bikes, but we're also very fortunate to have 2 other sites in the community that have FES bikes. So we work closely with the Don Wheaton YMCA and the Saville Community Sports Center, which is also affiliated with the University of Alberta. And so between there, individuals have a number of different choices once they get into the community. But that whole transition piece of going from rehabilitation to the community has been challenging when it comes to communication. So there's kind of misfires around what was happening, and there just wasn't enough talking, and the move from rehab to community was a little bit bumpy. So to kind of address that, we've been trying to really work together more. We've been having very focused meetings with folks from the rehab perspective, with myself here at the Stedward Center, and then with the individuals who are representing the other centers. So we're really trying to work together to have better coordination across our services. Ideally, we hope this means that participants have a more seamless transition as they're going across services. And ideally, this will increase opportunities across the city. So we're trying to support one another rather than thinking about kind of fighting for participants. We're trying to see how can we just make sure that we get more people more active more often in a way that works for them. We can also be more efficient when we work together. So Shane mentioned this whole challenge around training, and we've experienced that as well because we are relatively small. And so by connecting the rehab side of things with us and the other 2 sites, as we join forces, then we're looking at ways that we can offer collaborative training so that we can build on the knowledge and experience of the other sites. But also if we're bringing in somebody with some expertise and knowledge, how can we bring all of the staff members together so that we have more people who are more trained in a more cost-effective manner? So I think this will really be a key piece to helping us build capacity within the city. So these are kind of our local solutions here in Edmonton, but across the province, we're also having regular conversations with other communities. And so we have quarterly meetings to kind of check in and see who's doing what, how is it going, are there ways that we can support one another. So the Alberta FES Interest Group is also another great opportunity for us to improve this communication, where we have folks in the community and in the rehab sites who are really trying to work together. For those that are looking for additional resources when it comes to implementing FES exercise in community-based sites, we do have AltaStim resources available through the Stedward Center website. And so that's another piece that's out there for folks who are thinking about how can we implement FES exercise in a community space. So the main piece that I wanted to really highlight is this idea that improved communication does not just happen. You have to really focus on it and think about it and very strategically address it. So there's been a coordinated effort. There's been some resources coming from the Glenrose to support the actual day-to-day happenings, to make the meetings come together, to do agendas and minutes and all those little pieces that take time and effort. But it's really led to better conversation and hopefully better services across our community so that we have more people with SCI who are more active more often. So that's kind of my piece, is really focusing on this whole, what happens after they leave rehab? Where are they going in the community? So that's kind of my perspective. And I believe I'm turning it over to John.
Hi, thanks, Jennifer, and everybody else. Sorry, it's stuck on mute for a second there. I am the consumer engagement lead at the Rick Hansen Institute, and I'm an individual with spinal cord injury. I've been living with spinal cord injury since 1993. So this whole movement towards activity-based training has really become popular in the community of people living with spinal cord injury, and I think predominantly in the community setting. I don't think, we've seen, at least from my knowledge, it's not really widely adopted in an inpatient setting, but certainly becoming more prevalent in the community. And I think that the real demand is, with shortened stays and length of stays getting smaller and smaller. And I think earlier Kristen spoke about dosing and the sort of limitations on dosing in an inpatient setting lead people to being discharged from inpatient ward before they maybe feel that they've reached their ultimate neurological potential. And I think when we think of the higher prevalence of incomplete injuries, we're seeing more and more people who are striving to sort of see what they can achieve beyond what they managed to achieve during their inpatient stay. It seems to me that these sort of ABT centers are much more prevalent in the United States than in most other places. Again, they're becoming more and more common in Canada, but certainly they're more popular in the United States, where length of stay can be dramatically shorter than they are in Canada. I think some of the concerns, though, are that often the people that are working in these community-based ABT centers maybe don't have the same level of expertise as you're going to get in a neurorehabilitation center. And I think, when we think of the skill set of some of these neurotherapists compared to some of these people that are working in ABT, I think some of the techniques that are used or the strategies that are used can sometimes be a bit concerning. I think as a person who has an incomplete injury myself, and have had from a time when incomplete injuries were very, very rare, there's often a tendency to move towards compensatory movements, which I think we would like to try to teach people to have really symmetrical movements and well postured and well balanced movements. But with these incomplete injuries, sometimes some muscles in some areas are more active than others. And so you can start to develop these compensatory movements, which posturally can sometimes be compromising and potentially lead to longer term complications. I think we have to be cautious that people aren't doing exercises that might lead to, like I say, long-term issues. At the same time, there's a demand for this high-dose therapy that you can get in these community-based, activity-based training. I have to apologize, I'm not terribly familiar with the inpatient setting, so I'm going to stick more to the communications on the community area. But when you think about motivation and sort of people in the post-injury phase, how motivated they are to try to maximize their recovery, I think you get a high variance. So some people, I think, are much more highly motivated than others. And when you move towards this sort of elective community-based ABT, you're really hitting on some highly motivated individuals who are really trying to maximize themselves. So they're looking for those high dosages. And so I think that there's a strong need for this opportunity to get this high intensity training as people are trying to maximize their recovery. So if there are some strategies that we can use to try to increase the knowledge of people working in activity-based training centers, so that they're not, potentially causing harm to postural and again, these compensatory strategies, I think we should look towards that. And I think one of the big things that I think about is these, the sort of exciting new developments in neuromodulation, spinal stimulation and such, epidural, transcutaneous, where people are getting, actual neurological recovery, functional recovery. There's some evidence to show that there's neural regeneration that's happening as a result of this. So I think, as this research continues to grow and the evidence continues to grow, there's the high likelihood that this is going to move towards a clinical setting, which means we're going to have a lot of people that are currently living with spinal cord injury who are starting to explore new neurological function, and they're going to want, and there's going to be a huge demand for intense training to try to maximize that. So I don't see community-based ABT reducing. I only see it growing, and I see it as being a real sort of adjunct to what's currently being delivered in an inpatient setting, to try to allow people to maximize, because I don't think that our healthcare systems are really going to be able to increase the lengths of stay and the dosing that people are currently receiving in inpatients. So, trying to figure out a mechanism where some of this ABT training can be provided on a wider scale, and potentially also more widely reimbursed by healthcare systems or insurance systems, because the cost is still quite high for your average person with a disability, and can be out of reach for a lot of people. And again, being more cost effective than an inpatient or even an outpatient stay at a specialized rehabilitation center, it's a very viable option. So, those are just a few of my thoughts on the need, the desire, and some of the risks or concerns. I think I'll leave it there and maybe pass on to Chris, and maybe we'll see if there's some questions from some of that towards the end.
Thanks, John. So as Kristen said, I'm Kristen Walden. I'm a physical therapist, and I work at GF Strong and Vancouver General Hospital in Vancouver, as well as with the Rick Hansen Institute as a national clinical liaison. So I just wanted to tell you a bit more about the activity-based therapy summit Kristen spoke about that happened at the beginning of March in Toronto, that was supported by the Rick Hansen Institute. Next slide. So looking back at that concept of activity-based therapy that Kristen went through, next. There are constantly new technologies emerging for use for therapists and others to provide that neuromuscular activation below the level of lesion, the task-specific training, or a combination of both, with the goal of achieving that neuroplasticity. As John said, there's a lot of excitement right now around epidural stimulation and transcutaneous stimulation when used in combination with training or extensive rehab. And there are a lot of other devices and new technologies emerging constantly. So I think as therapists, it's challenging to know what devices we should be using when, how far post-injury, with which type of clients we should be using them, what should the dosage look like, what should the intensity look like. And so there's really a lot of questions, I think, out there that remain in terms of trying to figure out what sort of optimal rehab for each individual should look like to try and maximize that neuroplasticity. Next slide. So from a Rick Hansen Institute perspective, this is our mission statement, which is really to lead collaboration across the spinal cord injury community, just trying to support translation of evidence and best practices across the continuum, and improve quality of life for people with spinal cord injury. Next slide. So within that,
on the weekend, where?
Within that mission, our areas of focus, some of our areas of focus for the current funding cycle include supporting the development of both promising therapies for neurorecovery and neurorestoration, as well as optimizing the spinal cord injury care being provided across the continuum. And so we're really trying to work with the Canadian spinal cord injury community to try and support answering some of those questions around activity-based therapy. Next slide. So in terms of the ABT Summit, we collaborated with Kristin Musselman, who agreed to lead the development of the summit. And the goal of the summit really was to try and bring people together to create a Canadian activity-based therapy strategy for spinal cord injury, to look at what we know today about activity-based therapy in spinal cord injury and also in other disease conditions like stroke, and start to develop an action plan of priorities really needed to start to move the field forward. Next slide. So at the summit, we had 38 participants. And I have to say, one of the most interesting things was the diversity of participants who came. We really wanted to ensure that the priorities and the action plan that came out were informed by a broad group and were actually realistic in terms of what could be achieved for everybody who would have a role in how to move this forward. And when we sat down to look at who that would be, it was quite, as you can see, quite a diverse group. And it was very interesting to organize because this is obviously an area of interest. There we only had, I think, maybe 3 or 4 people who couldn't attend because they were on vacation. So there was a lot of interest in being part of developing this action plan. Next slide. So the aims of the summit really were to look at the evolution of similar work in the stroke field. There's been a lot of similar work being done, and in some ways they're a bit further ahead. Start to integrate that information and give feedback on what of that may be appropriate for us to look at in spinal cord injury. Try and get a handle on what does ABT look like currently across the continuum in Canada. Look at what do we want to be able to achieve realistically in the next 1 to 2, 3 to 5 years across that research care continuum, and start to look at where are our current strengths and where can we start in terms of brainstorming solutions to help us get there, and then trying to create a working plan to achieve those goals. Next slide. So at the summit, we reviewed things like this, which is the current Canadian traumatic spinal cord injury care pathway. So we just started to look at using the numbers from the Rickhanson Spinal Cord Injury Registry, who is going to inpatient spinal cord injury rehab, how old are they, who's not going. Next. We also wanted to look at how long are people staying. How long are they staying in acute care and rehab, so that we could really be informed in terms of what phase of care we should be looking at. If we're looking to implement different activity-based therapy solutions, where should we be targeting them? Next slide. So the majority of people who attended the summit also presented on their area of expertise. As you saw, there was a really diverse group in terms of expertise. So there were things from technologies around in terms of what we could use for monitoring activity-based therapy. Next. Through to wearable sensors, which seem to be evolving and emerging in this area for monitoring metrics about activity-based therapy, all the way to what to consider when looking at supporting the economic evaluation and trying to build the case for using activity-based therapy, knowing the intensity and the costs associated with it. This was definitely a very interesting presentation about, is it all about the Benjamins? Next. So the group took this, we looked at this overview kind of map of things we know and things we don't know related to neuro recovery across the continuum of care, and looked at kind of where we have data available and where we don't. And the group throughout the summit layered on current projects going on, research care across that continuum. So we could really get an idea of current activities going on in Canada and start to identify some of the gaps to address. Next slide. So in the end, the group identified five key priorities over the next 3 to 5 years. And so this lists the priorities from left to right in order of those that should be addressed more in the short term to those that will take a bit longer time. So the first was to identify the current activity-based therapies across the continuum. So what's currently going on? What does that look like? The second, as Jen spoke to, and Shane as well, is really to start to create a network to facilitate dialogue between hospitals, rehab centers, and community groups. The third was to be able to track engagement in activity-based therapy activities across the continuum. You know, even deciding what metrics should be used around intensity is in question. The fourth is to develop and implement some kind of best practice recommendation around ABT. So start to bring everything together to start to answer some of those questions. And the last, which will take the longest, is to start to study the optimal timing. What's the optimal timing? What are the optimal methods and dosing of activity-based therapy to promote those outcomes, that neuroplasticity? And along the bottom in that arrow, the group identified some themes that really need to be considered throughout this process. So consideration of both upper and lower limb, considering behavior change strategies, knowing that this is going to be a large change from current practice in some places. An eye to that economic analysis or building the business case for why this is cost effective. Really looking to innovative collaborations, keeping an eye on technology and data and how that can support all of these initiatives. And then with the goal of really having some impactful research that can be used practically. Next. So if we look at actions to date since we had the summit, currently the group's working on writing up the summit overview and that working plan in the form of a white paper, so that's being drafted. They have formed a working group around the priority of identifying current activity-based therapy activities across the continuum, and have gotten ethics and have started doing a survey of activity-based therapy technologies used across the continuum. So as Shane was speaking of, every center has different technologies available to them and different barriers and facilitators to using them. I think everybody has that piece of equipment that was new and really cool, and then ended up sitting in a closet or in a room somewhere that doesn't really get used. So this is just to look at what technologies do people have available to support activity-based therapy in acute and rehab centers, and what are the current barriers and facilitators to actually using them. Next slide. And then around that second priority of creating a network to facilitate dialogue. So currently we've just started to create a network with the people who attended the summit. So they're all connected. And there is also a Canadian Spinal Cord Injury Clinician Directory that's not restricted to activity-based therapy, but it is a directory of clinicians working across Canada with individuals with spinal cord injury, where you can find contact information, where people work, areas of interest for them, to start to create that network as well. Next slide. So this is just some information on the Canadian Spinal Cord Injury Clinician Directory, if anybody hasn't heard of it and is interested in being a part of it. Down in that How Do I Join section at the bottom, it just tells you the website. Just go on. Next slide. So I think with that, I'll hand it back over to Kristen, and we'll open it to you guys for questions.
Yeah, thanks everybody. That was great. And we do have some time for questions. I'm just going to flip back to Chris's slide here. So if anybody wants to take down the website address, they can. So yeah, we have maybe 5 minutes. If anybody has any comments, questions, feel free to unmute your mic and you can speak up, or there's also a chat box. You can send a chat that way as well.
Very quiet out there. There's got to be somebody with a question.
Well, we're doing this all over again in 5 minutes, so we will be staying on the line. If anybody thinks of a question in the next 5 minutes, feel free to pass it forward. But if not, thanks everybody for attending. Really appreciate your interest and taking the time to learn about ABT. So we do have a question. There's a question from Louise. Can ABT be done in the community setting without the use of technology? So for example, at home, which is a fantastic question. Is there somebody who wants to answer that? Or do you want me to answer it? Any takers? Well, I'll get started, then somebody can jump in. So Louise, absolutely, it can be done at home. You don't need, you can still engage in ABT without expensive or fancy equipment. It's all about just meeting those key ingredients or those characteristics. So trying to make it intensive and task specific, and using as appropriate movement patterns as possible. So there are ABT, people who are engaged in ABT who are not using technology, or very simple pieces of equipment. Another question about getting a copy of the slide of the presentation. Yes, we recorded it, so we will have a recording that will be posted through the Neurosciences Division, the FES interest group, also through the networks at Rick Hansen Institute. If you're not part of any of those groups but would like either the slides or the recording, if you could email me or Chris Walden, that would be great. And for anybody just joining the line for the next presentation, if you could mute your mic, that would be fantastic. Okay. So I'm getting a little behind here. So what is the current status of the survey? Is there a timeline of when the survey will be distributed? So that's coming from Dalton and London, Ontario. So we've done one test run with the survey at one site, and it generally went quite well. So we just have a few little details we want to fix, and then we will be recruiting more broadly. So we'll be in touch with you about that, Dalton, because I know that you're going to be helping with that project. I hope. Oh, and Anita has a great comment here. So a fundamental component that was alluded to but not emphasized is the importance of motivated mental effort on behalf of the client during performance of ABT. So thanks, Anita. I'll make sure to emphasize that the second time around. But that is a good point. And one thing that is very important if you're trying to promote neuroplasticity, the individual really does need to be an active participant in the therapy, and that's well established in the FES literature, as well as the robotic literature for gait training. So that's an excellent point. Thank you. Okay, so we're almost at the top of the hour. I'm going to stop recording, and then we'll start again in a minute or two, if that's okay with everybody.